Good evening, Sachin sir.
Good evening. Shall we start?
I think we should start. So, good evening to all the participants of this hematology certification course. And we welcome Dr. Sachin Jadhav sir again, who is the chairman of International Hematology Consortium, CEO of Chiron. And today it's going to be a very interesting topic, I think, which we have to indirectly pick up in many patients so that we, as primary care screeners, can come to a definitive diagnosis with the help of hematologist. The topic is multiple myeloma, and today we have Dr. Sachin, who will give us this enlightening session. I think, I'm sure, with his usual stories and his experience, just for the benefit of participants. So, Sachin sir is taking this bone marrow aspiration biopsy workshop and difficult IV access, which we will all be able to attend in Wonka conference on 6th of April at Sheraton Grand, and we'll be sharing the registration soon. So if you all want to attend this workshop, participate in the conference. And also, one more thing, please, log in with your full name. We are checking on attendance. We are keeping a good track record of everything. And do participate in live sessions so that it becomes very interactive and you can clear all your doubts regarding hematology than just hearing to recorded sessions or understanding through PPTs. I think one-to-one interaction, it is a golden opportunity to be with a hematologist around who can understand the level of thinking of primary care providers. So over to Dr. Sachin. Good evening, sir, and over to you, sir.
Thank you so much, Dr. Soumya. Good afternoon, everyone. Today, we are going to talk about multiple myeloma. And like Dr. Soumya correctly mentioned, truly speaking, the diagnosis of multiple myeloma is on our friends who are working in the community. So whether it is physicians or GPs or orthopedicians, nephrologists, multiple myeloma is one type of cancer which presents because of its complications, usually. Yeah. So most of the cancers, for example, breast cancer will present with a lump in the breast. Correct? Colonic cancer will present usually with some GI symptoms. But multiple myeloma is a type of cancer which presents more because of the complications that it causes. And patients often reach all of you guys with these complications, and hence a high index of suspicion is essential so that we don't miss these patients. So, we've discussed this in our bones. We have bone marrow, and bone marrow is a factory which makes all the blood cells. Now, one type of blood cell that we did not speak about is the plasma cell. Plasma cell is a wonderful cell in our body. It is created, it evolves from B lymphocytes, which later on then could mature further. And plasma cells by themselves, their job is to make antibodies. Their job is to make immunoglobulins. So whenever we get any kind of infection, whether it is COVID or influenza, or tuberculosis, syphilis, any kind of infection, the job of a plasma cell, of normal plasma cell.
అక్కడే సుధాస్ బోట్ ఇక్కడ KFC ఆపోజిట్ లో అక్కడే కొనాలి ఎక్కువ కలెక్షన్ ఎక్కువ.
Yeah.
Request participants, please mute your mic. Be consciously muting your mic.
Yeah. I muted everyone, Dr. Soumya. Okay. So what essentially it means is whenever a bug enters our body. So suppose during the COVID pandemic or even now, right, some of us are getting COVID infection. Whenever the COVID bug enters our body, It is encountered by the immune system. The system comprises of neutrophils, macrophages of different types, plasma cells, T lymphocytes, B lymphocytes, and all of these, this immunity comes together, and some cells will directly eat up the infecting bug and kill it. Whereas what the other cells will do is it will identify the antigenic portions of the bug. So what that means is there are cells in our body which will decide that, hey, look, this is the protein on the surface of this bacteria or this virus or this fungus, which is different from my protein, human protein. It is a non-self protein. It's not a self protein. It is a non-self protein. These immune cells will then process these non-self proteins and then present it to the plasma cell. And the job of the plasma cell is to create antibodies, which these antibodies are created in the cytoplasm of the plasma cell, and they are secreted out in the blood. And these antibodies are supposed to float around in the blood and go to all parts of the body. And wherever the antigen is present, they're supposed to bind the antigen and help the immune system from locating the antigen and killing it. Correct? So this plasma cell per se is not moving around in the body. Remember, this is important. Plasma cells will sit in the bone marrow. Their job is sitting in the marrow and being a factory for antibodies, for immunoglobulins of different types. So, for example, my body may have some small number of plasma cells which will create antibodies to hepatitis B because I've taken hepatitis B vaccine. I will have some small group of plasma cells. They can create antibodies to COVID or diphtheria or tetanus, right? So next time in my life, if I get this infection again, if I get COVID again, or if by chance I get a needle prick injury and hepatitis B, the plasma cells which are ready, they will immediately start manufacturing specific anti-hepatitis B, anti-COVID antibody to go and kill that bug so that it does not multiply and it does not harm me or affect. So that is what a plasma cell does. What this also means that in my body, I have different clones of plasma cell. Now, clone means copy. Clone means copy. So we have one person, and that one person can be cloned into 2, into 4, into 8, into 16. So my bone marrow, my body has multiple different clones of plasma cells. And there are also plasma cells which are not yet mature, they're not yet clonal, they have not yet experienced any infection. And whenever I get an infection, these plasma cells will mature. Now remember, once it is cloned, that group of plasma cell can only produce that antibody. Okay, but my body has multiple clones. So if you actually do take a blood sample and you send it to the biochemistry lab, and in the biochemistry lab, you do liver function test. In the liver function test, we usually look at the bilirubin and we look at SGOT, SGPT, and alkaline phosphatase. But as a hematologist, I look more at the total protein, albumin, and globulin. Okay. For me, the proteins in the blood are important. Now, if the proteins in the blood are, albumin and globulin, and they are combined called as total protein. So if the globulins have increased in the blood, if they have increased in the blood, then I like to find out, are these globulins floating around in my body or my patient's body? Are they different kinds of polyclonal immunoglobulins, right? That means I will have antibodies, like I said, to, excuse me, hepatitis B, COVID, chicken pox. I had chicken pox in my childhood. I had a smallpox vaccine in my childhood. So there'll be different clones because there are different clones of plasma cells making different types of antibodies, right? Different types of immunoglobulin. That's a normal immunoglobulin level in the blood. In our blood, we expect polyclonal. However, In some patients, what happens is, right, these plasma cells, one of them, the genome, the genetics in the plasma cell goes abnormal, and that normal plasma cell becomes cancerous, it becomes malignant. So one plasma cell will, can become malignant, and that will divide into 2, into 4, into 16, 64, 100,000, and lakhs, right? Now these lakhs of cancerous plasma cell, which are formed from the first one which became cancerous, the first one became cancerous, and then it has multiplied to give lakhs of plasma cells. They are all copies of this first one. They are exactly identical. They are clonal. They are Xerox copies, clonal. And because they are clonal, because they look the same, they also secrete the same antibody, the same immunoglobulin. Okay, it's a clonal population of plasma cell which secretes monoclonal antibody, monoclonal immunoglobulin in the blood. Now imagine these cancerous plasma cells are going to multiply. They're going to pack up the marrow. Yeah, hence there will be no space for normal plasma cells. Hence, different types of antibodies which are essential for fighting infections are not produced, and this cancerous clone of plasma cell is only making the same type of useless monoclonal antibody. It is just one type, it cannot protect the patient from different infection. Now this is a core concept that we need to remember. Now, once we understand this, what we will do is, okay, sure. So now a patient of myeloma has a cancer of plasma cells. These plasma cells are all clonal. They are all copies of the same first plasma cell which became cancerous, right? And then what does it do? What all can it do? Okay. Now, again, myeloma is a different kind of disease. Like I said, in other solid tumors, the cancer cells will multiply and they'll form a tumor. They'll form a lump, a swelling. Hence, we call it OMA. OMA means tumor. So breast cancer, cholangiocarcinoma, whatever. The cancer cells will multiply and form a tumor. However, you see, bone marrow is not a solid organ. It's kind of jelly. It's like a semi-solid. So as the plasma cells multiply, they can spread around the bone marrow. Hence, we may usually not get a single lump of cells. These are going to spread out in the bone marrow. They're going to infiltrate in the bones, and they're going to damage the bone. They are going to take up space. They will not allow the normal marrow to work. They will not allow hemoglobin, WBC, and platelet production. They will also not allow any normal plasma cells to grow. Yeah. So obviously, when myeloma happens, we're going to get low hemoglobin. Most of our myeloma patients generally have at least slightly low hemoglobin. Okay. The second thing that happens is as these plasma cells spread in the marrow, they will damage the bone around them. They'll damage it. And it dissolves the bone, dissolves. It makes holes in the bone called lytic lesions. And we see these lytic lesions on X-ray. Yeah, there are these, if you can see here, there are like holes in the bones. And sometimes the bone becomes so fragile that it can fracture. It can fracture even without a lot of injury, even without trauma, even without major pressure. The most phenomenal kind of fracture that I have seen, phenomenal in the sense it was mind-boggling, was a pediatrician from Nigeria. This was a doctor in his 50s, if I'm not mistaken. I saw him about 9-10 years ago. He was the head of department of pediatrics in a major hospital in Nigeria. And as usual, one morning he went to work, and he tried to pick a file, a simple box file. You know how light that is, right? A box file from the top of a cupboard. And just that weight of the box file fractured his humerus. It fractured the humerus. So humerus had become so thin and so many lytic lesions that he got what is called as a fragility fracture. So quite often our patients will present with such fragility or pathologic fractures. They may get a fracture neck femur without even falling down or with minor trauma. They may get vertebral body collapse just like that. Normal life, they come with back pain and we say there's a vertebral body collapse because the vertebral body may be infiltrated with cancer cells, with plasma cells, right? So that's how these cells can damage the marrow. As they are damaging the bones, remember, bones are a solid store of calcium. They are a storehouse of calcium. And as the bone gets damaged, this calcium gets released from the bones and it enters the body, it enters the blood, and hence the serum calcium goes up. This is usually asymptomatic. We find this only when we do the blood test, only when we do serum calcium. But rarely some patients can get metastatic calcification. That means calcium can go and get deposited in different parts of the body. And if that happens in the heart, it can cause conduction blocks, but this is very rare. I've only seen one patient in the last 20 years, right? So we have these plasma cells which are multiplying, and on the other hand, they're also secreting this useless, abnormal monoclonal immunoglobulin. This immunoglobulin is either it can be IgG, IgA, or IgM. Okay, so immunoglobulin A, M, G. These are the commonest types. However, an immunoglobulin molecule contains a heavy chain and a light chain, heavy chain and a light chain. And sometimes the myeloma cell, the cancer cell may be so damaged, it may be so defective that it can't even make the complete immunoglobulin. It can't make immunoglobulin A or G or M. It only makes the light chains. And in that patient, if we look at the liver function test, the globulin fraction in the total proteins will look normal because the cancer cell is so defective. It is not even making complete immunoglobulins. It is only making light chain. So these patients are only diagnosed by what is called as a free light chain assay. So the immunoglobulin may be complete IgG, IgA, IgM, but monoclonal. So we find it on electrophoresis, or it might just be light chain. And for that, there is a different test that I'll tell you. Now, this light chain myeloma is very notorious because, like I said, the globulin total, amount of globulin in the blood looks normal. So we tend to miss the diagnosis. And at the same time, these light chains can go into the kidney and block the kidneys. It blocks the kidneys. It precipitates in the renal tubules. So these patients, especially light chain myeloma patients, often present with acute kidney injury or or quite often they have chronic kidney disease going on and they may even be on dialysis and nobody may realize that this CKD, this renal failure, is because of myeloma. And if we treat the myeloma, maybe the kidney function will recover, right? So broadly speaking, this is how multiple myeloma presents. Yeah. Now, in patients who have kidney disease due to myeloma, remember they have normal sized kidneys. So any patient with CKD, typically what we will all do is we'll do an ultrasound. And if the kidneys are small and shrunken, that's your garden variety CKD. But if the kidneys are of normal or large size and the creat is high, then the differential diagnosis is different. The differential diagnosis may be a diabetic nephropathy. The differential diagnosis may be myeloma, which is actually causing renal failure, right? So small shrunken kidneys, not myeloma. Normal size kidneys, think of myeloma, okay? How do we actually diagnose? Now, like I said, diagnosis is tricky because there is no lump, there is no tumor that your patient will come with. And there are just these plasma cells which are scattered. And, whenever you do a marrow and you see plasma cells, if your pathology friend says, look, I am seeing 20% plasma cells, this must be a myeloma. You can ask, why are you saying myeloma? Can't these plasma cells, 20% plasma cells. Yeah, sure. Normally, we don't have more than 5%. But can these just be reactive? Can they be normal plasma cells which are multiplying because of an infection? How can you say that this is a cancer, right? Can't they just be normally multiplying plasma cells? Well, for that, you have to show that the plasma cell is clonal. Clonal, that all the plasma cells are identical, that all of them are IgG or IgA or IgM, or all of them have this light chain. So you have to show clonality. You have to show that, hey, look, these are all identical. They're Xerox copies. So they can't be reactive, because in reactive, we get different, the plasma cells are not identical to each other. They have not formed from one. They formed from multiple different infections. So that's something that we have to think of. Often we get patients saying, no, no, there are high plasma cells. Can it be myeloma? We look at clonality. Are they clonal plasma cells or not? Then you will have patients who come with fragility fractures or lytic lesions. I had again another lady about in her early 60s, again 9, 10 years ago. She was being posted for knee replacement, right-sided knee replacement, right? And she had this typical knee pain. Everything was fine. And the orthopedician said, hey, look, this looks like osteoarthritis. You have you're still reasonably young and active. You should get a knee replacement. So she was posted for knee replacement. And a day before the surgery, they again repeated the x-ray of the right knee, which was supposed to undergo surgery. And the orthopedician thought, no, I'm not sure, maybe there's a lytic lesion. And in usual osteoarthritis, you don't see lytic lesions. So he sent the patient to me. He said, Sachin, can you look at it? And it turned out that she actually had knee pain because of myeloma. The lytic lesions where guided us to the diagnosis. And when we treated myeloma, the knee pain went away. She never required a knee replacement. Yeah. Sometimes pre-op, the anesthetist may say, hey, why is this patient's hemoglobin only 6? And then when we do a liver function test in the LFT, the globulin is high. And we say, hey, man, let's rule out myeloma. Maybe the patient has presented with anemia. Okay. But all lytic lesions are not myeloma. There are many different kinds of cells which can infiltrate the bones and break down the bone, cause holes, cause lytic lesions in the bones. They can be solid tumors like breast cancer, CA prostate. CA prostate usually does not have lytic lesions, but multiple different kinds of solid tumors can also call lytic lesions. So how do you diagnose myeloma? Immunoglobulins, I told you, it can be polyclonal because of infection or monoclonal. Renal failure has n number of causes. Anemia has n number of causes. So how do we actually diagnose myeloma? Now that is where CRAB comes in. CRAB, C-R-A-B. And I'm sure all of you know what a crab is. Crab, these are the shelled organisms which are there on the beach, right? Or sometimes even in rivers, by side of rivers. These are crabs. So crab, C-R-A-B, these four features are called MDE, myeloma defining event. So you have any of these with crab, more likely to be myeloma. Okay, so we use this MDE or CRAB, myeloma defining event, to differentiate myeloma from other causes of anemia, renal failure, lytic lesions, etc. So what's CRAB? The first C is high calcium. High calcium. How high? Even 1 milligram more than upper limit of normal. Remember, our body biology is amazing. The way nature has created our bodies, we have a very tight control on sodium, potassium, calcium, phosphorus. You know, in spite of having trillions of cells, there is such a tight control. So if the calcium is more than 1 milligram per deciliter, higher than upper limit of normal, or if it goes above 11, we say hypercalcemia. That's the C of crab. Two, renal failure. What do we mean by renal failure? A drop in creat clearance or creatinine goes more than 2. That's R. Then A, anemia. Okay. What do we mean by anemia? If the lower limit is say 11, if it's below 9, so more than 2 grams below, or if the hemoglobin drops below 10, the last B is bony lesion. Okay. Now I'll explain to you how we use these myeloma defining events. So calcium, renal failure, anemia, bony events. All right. I'll come to this. The other thing is the plasma cells which we see, they have to be copies, they have to be monoclonal. And the monoclonal immunoglobulin, the M band, must be very high. Little bit of M band may not be myeloma. Okay. Slightly high free light chain. So light chains are kappa and lambda. Slightly high lambda, slightly high kappa may not be myeloma. So how many plasma cells are there? How much is the M band? The monoclonal protein. M stands for monoclonal. How high is the light chain? That's also important along with CRAB. So if these high number of plasma cells, very high monoclonal M band, very high lambda or kappa free light chain assay, plus even one of these means it's myeloma. So what I'm telling you is, if you see a lot of plasma cells, but if they are not increasing calcium, if they are not causing renal failure, not causing anemia, not causing bony pains, and if the high number of plasma cells in the marrow are not clonal, then you can say this is not myeloma, this is polyclonal plasma cytosis, reactive to some infection. So all of these criteria have to come together for us to call something myeloma. So now let us see what are the different kinds of plasma disorders. Okay. So like I said, you have somebody where in the liver function test, you have seen high globulin. Okay. What do you mean by high? Higher than albumin. Easy to remember. If the serum globulin is more than albumin, it is high in your LFT. Or somebody says, I have done a bone marrow, there are a lot of plasma cells. Or I have done a biopsy from collapsed vertebral body, there are a lot of plasma cells. Or somebody says, hey, there was a tumor in the humerus, I have done a biopsy, there are a lot of plasma cells. Is this myeloma? Or somebody comes with a fracture, especially fragility fracture. Somebody comes with renal failure. Somebody comes with high calcium. Okay. So presentation may be different. First thing that we do is we say, hey, let's just do electrophoresis of the protein. Electrophoresis. What is the meaning of electrophoresis? It means there is a gel. Okay. There is a gel. You put serum in that and you put positive and negative electrodes. Now the serum has a lot of proteins, and some proteins may have a positive charge, some proteins may have a negative charge, some proteins may have a neutral charge. But if I put positive and negative electrodes, the positive proteins will get pulled towards the negative. The negatively charged proteins will get pulled towards the positive electrode, and the those which have a neutral charge will stay in between. So essentially what I'm doing by electrophoresis, I'm spreading out the proteins. I'm spreading out the proteins. Then positive ones go here, negative ones go here. And thus what was actually serum with all kinds of proteins is now spread out. The different kinds of proteins are spread out. Okay. Now when I'm doing electrophoresis, if it shows that this patient does not have different kinds of proteins, there's only one kind of protein, that's monoclonal, because those proteins are all together, they have the same size, they have the same electric charge. So in a patient in whom we get a single spike, monoclonal. When I do electrophoresis, I'm not getting different types, I'm getting one single spike. This patient's blood has one single monoclonal protein, a mix of, same type of immunoglobulins, monoclonal. So on serum electrophoresis, if I get polyclonal, it's reactive. It's not myeloma, guys, because that's what I expect in a normal person, multiple different kinds of immunoglobulins. However, if there's monoclonal, well, it could be a plasma cell malignancy. Yeah. However, if this monoclonal protein is very small quantity, yeah, less than 3 grams, and I have also done a bone marrow exam, and bone marrow has less than 10% plasma cells. And there is no crab. There is no crab. That means there are very few plasma cells. There is no high calcium, creat, anemia low, hemoglobin low or fractures. Yeah. And even the monoclonal protein is very small. Then we call this MGUS. MGUS, monoclonal gammopathy. Gammopathy means immunoglobulins. So there are monoclonal proteins, but they're less than 3 grams. Okay. So monoclonal gammopathy of uncertain significance. That means, yeah, there are some monoclonal proteins, but they're less than 3 grams, very few plasma cells, no crab. Okay. I don't know what this is. This is uncertain significance. This is MGUS. MGUS. Now, mind you, you will say, but Dr. Sachin, there are some clonal plasma cells. No, yeah, they are less than 10%, but they are there. You may say, Dr. Sachin, there is a monoclonal protein. It is less than 3 grams. Say, yeah. It's there. It is uncertain significance. Amongst all the patients who have MGUS, and MGUS is very common in 70, 80 years of age, we often get consultation from physicians, nephrologists saying, hey, one of my patients has M-band. We see M-band is very small. We do a marrow. There's nothing much. They say, hey, this is MGUS. Sure, MGUS is an early stage of myeloma. It's a pre-malignant stage of myeloma. There are some clonal plasma cells, but they may not multiply to form full myeloma. Okay. Not all crazy people turn into terrorists. We all know 100 or 200 crazy people. Not everybody turns into terrorists. Similarly, not every MGUS patient will turn into myeloma. Only 1%, only 1% of patients with MGUS per year will actually get myeloma if you follow them for the next 20 years, which means 99% of patients of MGUS don't progress to full cancer, don't progress to full myeloma, but they can have neuropathy. They can have neuropathy. Okay. And we have to watch them once a year. We have to watch them once a year. Just a minute, please. We have to watch them once a year to see if this MGUS patient is progressing. Now, sometimes what happens is they progress slightly. What do you mean by slightly? Which means after a few years, now your M band is more than 3 grams. There's also some M-band in the urine protein. Your plasma cells in the marrow have increased. Up to 60% of the marrow cells are now plasma cells. Okay, but they still don't have crab. They still don't have crab. And these are called smoldering myeloma. Smoldering myeloma is like a smoldering volcano. It's like a smoldering volcano. Volcano is rumbling, but it has not burst as yet. Okay? And you're scared, hey, maybe that volcano will burst and kill the people living near it. Similarly, in smoldering myeloma, yeah, the monoclonal protein is growing more than 3 grams. The plasma cells are multiplying. They are now almost up to 60%. But as of now, there is no organ damage, no crab, no MDE. We will just call it smoldering myeloma. Again, we have to closely follow. And now there is current research going on to see should we actually treat smoldering myeloma. But not all patients with smoldering myeloma will actually get full myeloma, right? So should we treat everyone? Should we give everyone chemotherapy, transplant, etc.? As of now, no. As of now, no. So these are all early stages of myeloma, the way the disease progresses. And once there is CRAB, once there is myeloma defining event, we call it myeloma. Okay. So even if the amount of M-band is small, but if there is crab, we will say, hey, probably you have myeloma. Okay. Because now there is organ damage. So this is the approach to diagnosis of myeloma. Of course, not every patient is like this. In some patients, the plasma cell is so bad, it is so badly damaged by the genetic mutations in it that it can't even make a light chain, forget a full immunoglobulin. So in those patients, if you do serum electrophoresis, there is no M-band. In those patients, if you do this free light chain assay, you're not going to get anything. So these patients are called non-secretory myeloma. So just because there is no M-band also doesn't mean that you've ruled out myeloma. Okay, you have to see what is the percentage of plasma cells. You have to see if there is any crab. And if that is there, maybe it's a non-secretory myeloma which can't secrete IgG, AM, it can't secrete lambda or kappa light chain. Okay. Then there are some patients who have solitary plasmacytoma. That means in one lytic lesion, the plasma cells grow and they make a small tumor in the bone. This is what my pediatrician friend from Nigeria had. That's a solitary plasmacytoma. Okay, that is one tumor of cancerous plasma cells. And I have to do biopsy and I have to show that these are clonal plasma cells. Okay. And I have to do a whole body CT, MRI, or PET CT and show that there are no other lytic lesions anywhere. It is a solitary plasmacytoma. I also have to do a bone marrow from the posterior superior iliac spine and show there are no plasmas, excessive clonal plasma cells in the marrow. It's all in one place here or vertebra or wherever. That's a solitary plasma cell. That's a rarer variety of myeloma. Okay, and of course they have no crab, but at one place they have a monoclonal plasma cell. And the poorest prognosis are in those patients where these plasma cells are not just sitting in the marrow, they have entered the blood. They are very aggressively multiplying and they are entering the blood. Remember, normal blood does not have plasma cells. Normal blood does not have plasma cells. They are all supposed to be in the marrow and marrow only. However, if the blood shows more than 5% plasma cells, we say, hey, look, now you have gone into the leukemic phase. Plasma cell leukemia. Leukemia means cancer cells are floating in the blood, right? These patients generally have a very poor prognosis and we have to treat them very aggressively. And in the last 10 years, I have seen about 5 patients with plasma cell leukemia, and only one survived for almost 2 years. That's it. Everybody else died within 6 months. So this is a very bad disease. We have to give good treatment for it. Yeah. So once we have a patient, how do we actually work up? Well, you'll do a general examination. You will look for bony tenderness. You will look for lymph nodes, liver, spleen, as usual. You will send a complete blood count and peripheral smear. You know, the patient whom I said of plasma cell leukemia who survived for 2 years after transplant, the diagnosis was made by a phenomenal pathologist, hematopathologist. So I got a call from the lab saying, hey, Sachin, I am seeing plasma cells in this patient's peripheral smear. And I said, wow, you're a very good pathologist. And then we actually confirmed that this patient had plasma cell leukemia, right? So we do CBC peripheral smear, you'll do LFT to look for the globulin fraction, you look for calcium, creatinine, and you will do a serum protein electrophoresis or immunofixation. Okay, this is a better test. They are almost identical, but immunofixation is slightly better. Many times, if you're thinking of myeloma, the lab will say, Madam, you want serum protein electrophoresis or immunofixation. You want it quantitative or qualitative? You say quantitative. I want to know how much is the M band. Is it less than 3 grams, more than 3 grams? Also, on treatment, we will follow the M band. So we have to see whether the M band falls down or not. So we want to quantitate it. Remember, do quantitative testing. Okay. This will tell us whether polyclonal, monoclonal. If it is monoclonal, is it IgG or IgGA or immunoglobulin M? Is it kappa light chain, lambda light chain, etc. Right? And we also measure. So for example, somebody has IgG myeloma. At diagnosis, their IgG level will be very high. And because the bad plasma cells don't allow the good plasma cells to work, the IgM, IgA will be below normal. And as we treat, the M band reduces, the immunoglobulin, bad immunoglobulin goes down and the good immunoglobulin comes up. This is how we follow a myeloma patient who is getting treatment. We do this test called serum free light chain assay. I told you some patients will, the plasma cells will only secrete kappa or lambda light chain. Yeah. Urine also, we do 24-hour urine protein because we want to see if there is renal damage due to myeloma. If there is damage, again, we'll follow up. At diagnosis, somebody may have a 24-hour urine protein of, say, 4 grams. And as we give chemotherapy, 4 becomes 2, becomes 1. So we can see that the kidneys are healing. We can see that the creatinine comes down, right, as we treat. Of course, you'll do a marrow, you'll do an aspirate, refine, look at plasma cells. Do they look normal? Do they look abnormal? what percentage of cells are there, and you will do genomics. Remember, in today's world, there is no cancer treatment without genomics. If somebody is doing cancer treatment without genomics, that's just not right. Genomics, such as especially fish in myeloma, this test will tell us there are, 4 or 5 chromosomal translocation, which we know are bad prognosis. In these patients, we know the cancer will relapse faster. It will relapse faster. So for that prognostication, for that counseling, for planning treatment and follow, it's important to do cytogenetic evaluation, especially fish for the in the marrow. You can do flow cytometry to you know get a perfect plasma cell count, and after treatment, you can do flow cytometry to see the number of plasma cells, how are they going down, because flow cytometry is very sensitive. If on the flow cytometer testing of marrow after treatment, if you don't get any plasma cells, then we say phenomenal response to treatment. MRD negative, minimal residual disease negative, right? Of course, you will do imaging. Now, the poorest of patients who can't afford whole body CT, MRI, or PET CT, you can do X-rays, you know, and you have to do X-rays of the flat bones and the long bones. So spine, skull, pelvis, humerus, femur, AP lateral, and in that you will see lytic lesions. So now you've achieved a diagnosis. For prognostication, like I said, we use cytogenetics. We use the genomic. We want to see what kind of translocations does the cancer cell have. And we use this prognostic scoring system, revised international staging system, RISS. Of course, there are many more newer systems, but even now this remains the one which is used by everyone. For RISS, in the blood serum, we look at beta 2 microglobulin. We look at the LDH, and we look at the fish report, the cytogenetics, what I told you, the chromosomal translocations in the plasma cells. And using these three, we say whether it is RISS stage 1, 2, or 3. And depending on whether it is, blue is the good one, stage 1, stage 2, stage 3, overall survival. So, for example, you can see in the blue stage 1, 80% of patients are alive up to 60 months after diagnosis, so 5 years after diagnosis. However, in the RISS stage 3, at same 5 years, 60-month point, only 40% are alive. So overall survival is markedly different based on whether they are stage 1, 2, 3. Similarly, progression-free survival means how quickly will the cancer come back is also remarkably different, right? So this is how we prognosticate, and we ultimately move on to treatment. Now, this is a busy slide, and I don't want you to look at everything, all of this. But the most important thing is, before this, from about 2000 to 2014, 15, and 2015 till now, there are three eras of myeloma treatment. Before 2002, 2003, we were using chemotherapy. We were using chemo combination called as VAD. So vincristine, adriamycin, and dexamethasone. That was the only combination. Yeah, we also had cyclophosphamide. So using chemotherapy up to 2000 or so. However, as science progressed and we understood the genomics, we understand the microenvironment, we understood how the myeloma cell grows. It was understood there are some certain intracellular pathways which are hyperactive in cancer cells. And maybe if we target those pathways with medicines such as bortezomib and lenalidomide, we can kill the cancer cells targeted manner, and maybe the normal cells won't be damaged. So around 2000, targeted therapy started coming into myeloma. Today, we use this for everyone. We no more use chemotherapy. 10 years from that, about 2015, now we have immunotherapy. We now know that there are certain proteins on the cell surface, and you can give a medicine called daratumumab, which will only target that protein and only kill myeloma cells in a phenomenal manner. So now we are coming to immunotherapy. And also in the last few years, we have CAR T cell therapy. So myeloma treatment has progressed from chemo to, biologic agents to immunotherapy and CAR T cell therapy. However, what is clear, no matter what you are going to use, which medicine, combination of medicine in newly diagnosed multiple myeloma, NDMM means newly diagnosed myeloma, you have to use minimum three medicines, a combination of minimum three medicines. So you can't say, no, 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 I will only give bortezomib or I'll only give lenalidomide. No, you have to combine them with steroids. So we combine bortezomib, lenalidomide, dexa. We combine cyclophosphamide with bortezomib with dexa. There are different combinations are available. Minimum three medicines have to be combined. If the patient can afford, we nowadays add a fourth medicine called daratumumab. Okay. So we give this chemotherapy. Some of them are tablets, some of them are injections. They go all around the body. They kill plasma cells, which are scattered around the bones. Yeah. And sometimes somebody may have a fracture, very painful fracture, and over, or there may be a plasmacytoma impinging on the spinal cord. And over there, you can't wait for chemotherapy to go and kill the cancer cells. So in those patients, we also give short radiation there, a small dose of radiation to quickly kill the cancer cells so that it does not press on the cord and cause neurodeficit. So for a few patients, we need radiotherapy, but everybody needs chemotherapy, and we should give minimum three medicines, preferably four medicines combination in a protocol. That combo will reduce the number of cancer cells in the body. But now remember, myeloma is not a curable disease. It will come back in every patient sooner or later. It will come back. In some patients, it may come back in 3 months. In somebody, it may not come back in 12 years. I have a patient, I transplanted her 12 years ago. She's still in remission. But technically, we say, well, it's not curable, it can come back anytime. So we give chemotherapy first cycle, second cycle, third cycle, fourth, fifth, sixth cycles we give. And every 2 months, we measure the M band. We see if the monoclonal protein is coming down. Once we see there is good control, then we do an autologous bone marrow transplant, autologous stem cell transplant. Autologous meaning we collect the patient's own cells and keep them in the blood bank. Then we give them high dose chemo, high dose melphalan. This high dose melphalan will go and kill as many plasma cells as possible so that the relapse will be late. Okay. If you don't do transplant, the relapse is faster. If you do transplant, the relapse gets delayed to about 4 or 5 years average, right? And after giving high dose chemo, 1 day later, we give back the patient's own stem cells so that the marrow can recover from the side effects of autologous stem cell transplant. So this is how myeloma is treated. So yeah. Okay. So like I said, newly diagnosed, we decide if the patient is, less than 70 years of age, healthy, transplant eligible, based on the cytogenetics and IPSS, we'll say standard risk or ISS3, RISS3 high risk. We'll give at least 3 or 4 medicine, fourth being daratumumab, 3, 4 cycles, and then do a transplant. And you can't stop after transplant. You have to give maintenance chemotherapy. Small dose, only one medicine, maintenance chemotherapy for at least 1 to 2 years. Nobody knows how long we should give, right? But at least 1.5 year we try. In high risk patients, same thing. Give the same chemotherapy 3, 4 cycles. Once you have disease control, do an autologous transplant. But here, because they have a high risk of relapse, they have bad cytogenetics, right? Bad genomics. We give two medicines for maintenance, bortezomib and lenalidomide. Again, minimum 18 months, 1.5 year. So this is how a newly diagnosed patient is treated, right? And those who are too old for transplant or are too poor for transplant, remember myeloma autologous transplant can be done in 4 or 5 lakhs, which today every patient can get through most of the government schemes. So we really should transplant as many patients as possible. But if somebody just can't transplant, they're too old, they have too many comorbidities, And old in hematology means more than 70 years. At least in our department, we routinely transplant patients up to 71, 72 years if they are healthy. So if they can't go through transplant, sure, you give the same chemo, but you continue maintenance. Don't stop it. Continue maintenance until there is a relapse. What happens when the patient relapses? If the relapse is more than 6 months after you stop treatment, you can restart the same treatment. Otherwise, you can try the other medicines. There are 8, 10 different medicines and combinations available. You use whatever regimen has not been used, whatever the patient can afford. There's carfilzomib, daratumumab, pomalidomide, so many medicines. Most of them are actually affordable, right? And of course, there's CAR T cell therapy. There's something called as BITE cell therapy, that is bispecific T engager cell therapy, and then of course clinical trials. So we are starting a clinical trial with daratumumab. We are starting another clinical trial with fourth generation IMiD and all that. There'll always be newer drugs which are coming. That's how you treat a relapsed myeloma. Whether after relapse you should do a second transplant, yeah, if the patient is healthy, if the relapses happen late, and in really bad patients, plasma cell leukemia, autologous transplant will not work. You have to do allogenic transplant. Thank you. That's about multiple myeloma for you.
Thank you, Dr. Sachin, for that wonderful session. We have some questions coming up in the chat box.
Yeah.
So many of them want to know the dose of the chemotherapy agents given, bortezomib,
Okay.
bortezomib. Yeah.
In maintenance, we give 1.3 milligram per meter square once in 2 weeks. But it also depends on the tolerance. So, what matters is all of these drugs have unique side effects. So, bortezomib leads to peripheral neuropathy, right? And so, if somebody has peripheral neuropathy, what dose are you going to give? If they don't have, what dose are you going to give, etc., etc. But generally, it's 1.3 milligram per meter square once in 2 weeks.
I think as family physicians, first we have to pick up the indirect signs through which the patient comes to us and see if it fits down to the scrap criteria of defining multiple myeloma, and then keep the specialist in the loop. And our role would be more into coming up with proper diagnosis or early recognition of MGUS. Correct me if I'm wrong, sir. And then we should do the right referral, like how we put Dr. Sachin sir and his team into the loop.
Yeah, yeah.
And
Good.
any other side effects of these commonly used drugs? Suppose the patient is on triple regimen. You were saying about cyclophosphamide and bortezomib and steroid combination like that. What we have to follow up as primary care providers? What are the
Yeah.
do's and don'ts? And a little bit comment about vaccination. Is it advisable in such patients before we start these immunosuppressants or targeted therapy? What's your comment about these?
No, that's a wonderful question, and thanks for bringing this up. So, first of all, what to follow, that will depend on the regimen which is going on. Every drug, every protocol has slightly different side effects. Most of the newer medicines are well tolerated, and nothing much is required. But sometimes there can be, severe skin reactions, almost like a Steven Johnson. Sometimes the counts may drop, hemoglobin, WC platelets may drop. So, whenever we complete treatment and we send the patient back to you, to family physicians, and if they are on this chemo, generally we write down what you need to watch for specific to that protocol. That's one part. The second part about vaccination, since myeloma or most of the hematologic malignancies are cancers of the immune system, obviously their immunity is down. Now, we don't give vaccines when chemotherapy is going on because the vaccines are useless, right? For the vaccine to be immunogenic, the immune system of the patient has to actually get stimulated. But because we are giving chemo, the immune system is suppressed. So we don't give routine vaccines when chemotherapy is going on. Uh, Once the chemotherapy is over Of course, routine vaccines can be given. We recommend annual influenza vaccine for every patient. And of course, when you have an unusual situation like COVID pandemic, then even during chemo, we have given vaccines, understanding that the immunogenicity may not be enough and you may have to give more doses for a patient. So that's about vaccines. Dr. Divyashri Atreya is asking, so incidental lab findings, how do they present? Like I said, anemia, renal failure, high globulin, fractures. Yeah, that's usually how myeloma presents. For the well, the presentations are the same for light chain myeloma. That's Dr. Parvati asking. The clinical features are exactly the same. The only difference is light chain myeloma renal failure is more common, and we have to start treatment very quickly. We have to use particular drugs like bortezomib, carfilzomib, daratumab to try and reverse the renal dysfunction. Many patients go off dialysis if you treat them in time with the right medicines. The only other difference between light chain and usual myeloma is your electrophoresis will be negative. There will be no M band, but the free light chain assay will show, give you the result, the diagnosis. Any other question?
Sir, I have a question.
Yeah, Dr. Basak.
Um, Sir, just now you mentioned any tumors, they'll form aggregation and it will form a tumor called omas. Here in this plasma cells, it will be uniformly distributed in the marrow or sometimes in the bloodstream. But still we call it as myeloma. So why it is so? And
Fantastic
second
question.
one,
Yeah, okay.
plasma cells, it will form a one clone, as you mentioned, monoclonal. But still the terminology called multiple myeloma.
Yeah.
Why it is so?
So multiple myeloma means there are multiple lesions. Okay.
Okay.
Every lesion is made of the same clumps and clones of cells, but the cells spread through the bone and the blood to different bones, and there are multiple lytic lesions, hence it's called multiple myeloma. If there's only one lesion, we call it solitary plasmacytoma. Yeah, that's the second
Okay.
question. The first question, why do we call it myeloma? Because there's no tumor. Because in nowadays, we are diagnosing patients early, right? And we are diagnosing them before they can actually form a tumor. But in the past, 50, 60 years ago, patients would come with a tumor of the humerus or femur or vertebra. The myeloma cells will go on multiplying. There were no CT scans, right? They were just X-rays and fluoroscopy, and diagnosis would be delayed. And it would be delayed to the point where the myeloma cells would also form a tumor. And hence it was called myeloma. But fantastic question.
Thank you, sir. So your comments on Benjon protein in urine, sir?
Yeah. So Benz-Jones proteins, are also secreted by myeloma cells, and they come out in the urine, but they are not a very sensitive test for myeloma. Hence, we actually don't look at BJP anymore. For the last 10 years, I have never done Benz-Jones proteins. The immunofixation electrophoresis and free light chain assay are so sensitive. We are able to identify patients faster, and bench-joint protein doesn't really help us in early diagnosis. It does not help us in prognostication. It may help in follow-up, but not so much. So we don't, because there are better tests, we don't look at it anymore.
Thank you, sir.
Dr. Parvati wants to know which age group it is common.
Yeah, so it's usually a disease of the elders. Myeloma it does not occur in children. It does not occur in pediatric age group. If I get a call about a small child who has increased plasma cells, I'm more likely to think that no, this is probably reactive plasmacytosis. You have to look for an infection which is causing this. Because like I told you, even from MGUS, for it to become myeloma, only 1% of patients evolve to myeloma per year. So it is a multi-decade oncogenesis. It takes several decades for the cancer to reach a level where it causes CRAB. And hence this is seen in the 50, 60, 70-year age group. In our country, we do see it in the 40s, and I have seen two patients who were in the 20s, but generally it's 40, 50 years and above. That's the age group. Thanks for asking that. I didn't cover it in my presentation. Does this increase the viscosity of blood? Yes, very good question. So I purposely did not get into it. IgM, when IgM increases in the blood, the viscosity increases. And clonal IgM is usually a different disease. It's called Waldenstrom's macroglobulinemia. In that, we get hyperviscosity of the blood, breathlessness because of hyperviscous blood, visual changes because of hyperviscous blood. But that's a different disease. In myeloma, IgG or IgA, and even IgM, where it is not Waldenstrom, we generally do not see increased viscosity of the blood. So I have not touched upon these extremely rare diseases, including what is called as, organ restricted gammopathy. So there may be myeloma restricted to the kidneys, etc. I have not touched upon those really rare diseases. So how much is the
What
value
is
of...
the okay? What is the prognosis in myeloma with the present treatment? Can you comment about it?
Yeah. So myeloma without transplant, median overall survival. That means half of the patients will relapse within 1.5 to 2 years. Median, okay? So median progression-free survival in myeloma without transplant is 18 to 24 months. With transplant is about 4 years. With newer medicines like daratumumab, etc., is 5 to 6 years. So every 2 to 5 years, the myeloma is going to relapse, and you give second line treatment, and you again put it in remission, and they'll again stay in remission, and then there'll be a third relapse. So all of this continues until the patient passes away. So today, if previously patients would die within 1 to 2 years, today we have patients living for 15, 20, 30 years, provided we are able to give them treatment at relapse. Remember, most of the newer medicines are too expensive. And that's right, exactly the question that Dr. Soumya is asking. They're too expensive. The older therapies, cyclophosphamide, thalidomide, lenalidomide, 2,000, 5,000, 10,000 rupees a month, right? For 6 months. Everybody can get that. But your CAR T cell therapy is 40 lakhs, 50 lakhs, right? So at relapse, the most important thing is what treatment they can afford. Frontline treatment, everybody can afford. Everybody can afford frontline treatment because just there are so many old medicines which are so cheap. At relapse, when you have to give novel therapies where problems happen. Dr. Archana Sampath has asked, what is the value of globulin? Should we think of myeloma? So if you're in your liver function test, if your globulin is more than albumin, you should do a serum protein electrophoresis or immunofixation. Okay. If that is polyclonal, it's not myeloma. If it is monoclonal, you have to start working up for myeloma, or you have to, refer to your nearest hematologist or oncologist. So globulin more than albumin, and if do an immunofixation or a serum protein electrophoresis. Anything else?
I think there are no more questions because sir is active in the group as well for all your queries and concerns, and he does give suggestions even where to do the next best test and which lab would give you a better result. So we have sir always in touch with us. Thank you so much for that, sir, for a wonderful session and a very simplified version of multiple myeloma. I think after this, as primary care providers, we should think and get alerted when there is high calcium, at what level, what is the right electrolysis test. Even if you ask immunofixation, you need to ask for both quantitative as well as qualitative, as sir was pointing out, and so many, hyper alerts when we need to especially the rethink, especially normal size kidneys, and you have high protein and positive electrophoresis. What should you think? So many things sir has enlightened. Thank you so much for that wonderful session, sir. Sir, the next session would be on high hemoglobin, total count, and platelet, no, sir?
Yeah.
Okay. So we
Okay.
will be announcing that shortly with the link, and which date we will tell you in advance. Thank you so much, sir.
Thank you.
Good day,
And
sir. And please share the
Excuse me, sir.
recording.
yeah,
Somebody has a concern.
go ahead.
Sir, last class is exam, sir.
Yeah, I know. Yeah. So Dr.
Yeah, I have
Nishit has gone on
spoken. Yeah, I've
leave.
spoken to
Yes,
Dr.
so
Nishit. Clinical
he'll
friend, sir,
share.
is very busy. Give us just a week's time so that we will share you the link for the test shortly. So don't worry until you complete all the compulsory test, your results and certification will not be awarded, and we are also looking into your attendance.
Thank you. And if
Thank
you
you, sir.
discuss, if you post any patients in the group for discussion, many times I am not able to look at WhatsApp for 2, 3 days. But if there's a patient that you have, you want to discuss quickly, just pick up the phone and call, because it may take me time to look at the WhatsApp and respond. All right. Thank you, everyone. Such a pleasure. See you
Thank
in a
you,
week.
sir. Thank you. See you in a
Sir,
week,
thank
sir.
you very
Thank
much,
you
sir.
so much. Sir, please save the recording, Sachin, sir.
Yeah. Thank you.
Yeah. Thank you.